My name is Aubrey Stoch, just by the way, endocrinologist. I actually do drug development and clinical pharmacology principally, but I do have an interest in bone. And so it's wonderful to be here to be able to talk about a topic at the moment that's important, that endocrine historically hasn't been that focused in, because it's metastatic bone disease. It's something that it's fair to say is probably more in the realm, or has been in the realm more of oncologists, orthopedists, neurosurgeons, and probably internists. Although endocrine is at the heart of it, certainly from when it started out many years ago. And I don't know whether you see consults for metastatic bone disease, but it's not probably your bread and butter to the same extent that osteoporosis, hypercalcemia is, but clearly this is on the spectrum of hypercalcemia, moving a little bit more proximally, and we'll go into that. And it does fit into learning about bone in a bone module, so it's a very nice opportunity to think about it. What I'd ask is that you feel free to interrupt me as we go along, and that we keep this as interactive as possible. Thanks. All right, so talking about the skeletal manifestations, of neoplasia on the, sorry, the mouse. Okay, so what the sort of the form fruit and what you totally think about most often is focal osteolysis. But there can also be an osteogenesis component, and there can be other approaches where you have elevated calcium or actually even decreased phosphorus and osteomalacia. So to think about metastatic bone disease and the skeletal manifestations of neoplasia as existing upon a continuum, such that when this does manifest, it generally doesn't manifest as only one discrete entity, but elements of the other manifestations form part of this, as opposed to osteoporosis, which is a much more diffuse disease. This is clearly more focal. And so to think about it, and we'll talk about how most often patients present. When you think about solid tumors that metastasize to bone, they typically form one of two patterns, an osteolytic type of lesion or an osteoblastic lesion. When you think of the most common osteolytic lesion that's almost discretely or universally osteolytic, you think of multiple myeloma. However, there are many solid tumors, as the title is evident here, that have an osteolytic component, including breast cancer and lung cancer. But you will also notice that for osteoblastic lesions, you can find breast cancer, and you undoubtedly can find elements of lung cancer as well. But the one that does typically cause osteoblastic lesions is prostate cancer. And if you look on the lateral film over here, you see an osteosclerotic vertebra, which you typically would see. And when you do skull x-rays and you see lytic lesions, obviously in the past you used to think of multiple myeloma, but now there are far more sensitive modalities to picking up myeloma with when one does standard chemistry, paraproteins, etc., but to at least understand the history of this. Looking at some of the pathophysiology behind what happens is you've got a tumor cell bone interface such that the tumor cells get disseminated to the bone marrow, which, as you know, is a very metabolically active anatomical site. And you get this whole soil and seed hypothesis that if you distribute cells to the bone marrow, since it's metabolically active, that takes advantage of a lot of other components. So what you have over here is your osteoclast that's resorbing bone, and I'm sure you've seen multiple pictures at least of this element over the past number of days, liberating TGF-beta. TGF beta then binding to one of these cells, and the cell then releases PTHrP, which you're very familiar with, that stimulates osteoblasts to increase rank ligand or decrease osteoprotegerin, to co-opt osteoclast precursors, which bind to bone, resorb bone, liberate more cytokines, TGF-beta, and you entrain a vicious cycle over here. If I go to the next slide and show the osteoblastic metastases, in this case, you've got the tumor cell probably at the center, and it releases different fragments, whether it be PTHrP, inactive fragments, latent TGF-beta, binding proteins, it's FGFs, other proteins, and they're proteases which activate TGF-beta, then once again go into bone, causing osteolysis, liberating more, and you get this cycle that gets, this vicious cycle that actually gets entrained. So if you put the two side by side, tumor cell bone interactions are that the tumor cell liberates PTHrP, stimulates the osteoclast, resorb bone, releases more TGF-beta, stimulating the tumor cell, and it goes on and on and on. And on the other side, looking at the bone microenvironment, you've got the tumor cell doing its thing, and you're getting osteoblastic activity, recognizing, you know, that at the heart of this, in bone you typically have coupling of osteoclast resorption, bone formation, and sometimes you can get a vicious cycle there. In terms of metastatic bone disease, and some of this we just mentioned, is that bone provides a very fertile soil for these tumor cells to grow and to progress. In fact, bone is actually the third most common metastatic site. I mean, you can think of sites that you commonly think of like liver and brain and other sites as being pretty common. Bone is pretty much up there. About 250,000 cases a year, accounting for almost 100,000 deaths per year. The tumors that commonly metastasize to bone include actually thyroid, breast, lung, prostate, and renal, but the other ones that can also occur from the GI tract, including pancreatic, colon, gastric, and of course ovarian as well. And so you just have to think about it, because it's not a typical manifestation until you have metastatic involvement. The predominant target is the red bone marrow of the axial skeleton. So I'm certain that you've been thinking about the trabecular bone and the cortical bone as you've been talking about osteoporosis and other aspects, and recognizing that the turnover in trabecular bone is faster than the turnover in cortical bone. So if you measure bone mineral density, say for osteoporosis, after you initiate treatment, or if someone goes through menopause, you'll see much quicker bone loss at trabecular bone sites, such as the vertebrae or the ribs, as opposed to cortical bone sites. Similarly, because you've got more active bone at trabecular bone sites, those are the sites that tend to be very inviting to tumor cells to do their job. So they tend to metastasize to red bone marrow, the red bone marrow, the active trabecular bone sites of the axial skeleton. So that's why you get metastases quite frequently in ribs, vertebrae, and the proximal long bones, and extensive osteoclastolysis mediated by the osteoclast. Before we go on, any questions or comments thus far? I want to keep it interactive and not make it that tiring for you guys. You've had a lot of lectures, I can see, and you've got you've got bone rounds to follow. But how does metastatic bone disease manifest? Okay, and the typical finding, unless it's asymptomatic and you pick it up because you're doing an imaging study for some other reason, is bone pain, impaired mobility, a pathological fracture, breast cancer accounting for quite a number of those. Spinal cord compression, and you get other manifestations such as hypercalcemia and osteoporosis and osteomalacia, although the latter manifestations are a little bit less frequent today. And so it's important to think about it, because that's where the coordinated care comes in with an orthopedist, with a neurosurgeon, with the oncologist, because of the way it tends to manifest. Breast cancer, you all know, leading cause of death, well over 200,000 cases a year. Also being aware of the men obviously get breast cancer. That's no secret to endocrinologists with gynecomastia and other manifestations to think about. Skeletal metastases occur in 3/4 of the patients with advanced disease. Now, it is possible that the phenotype may change over time, because you've got far more active therapies that have emerged in oncology. Yes, getting beyond the world of chemotherapy, getting into targeted therapies such as tyrosine kinase inhibitors, and more recently immuno-oncology, checkpoint inhibitors. Perhaps the shape of what you see is going to change. Notwithstanding that, unfortunately, in many instances, disease still progresses and it will manifest, and you will still have instances of metastases. Up to 1/3 of the initial sites of relapse are seen. And the median survival after someone has a bone metastasis is about 18 to 20 months. In terms of prostate cancer, obviously a very common cancer in men, and many men with prostate cancer live for a considerable period of time and are likely to manifest with a metastasis. And once again, you're talking about well over 200,000 cases per year and quite a number of deaths in the United States. About 9% of men at the time of diagnosis would have a distant metastasis. Skeletal metastases seen in 85% of those men with prostate cancer with advanced disease. We mentioned that you tend to get an osteosclerotic lesion, and survival with prostate cancer tends to be longer, on the order of 3 years or so, and hopefully much longer than that with the newer emerging therapies. So when one thinks about metastatic bone disease, we discussed some of the clinical manifestations previously. When trials were initiated, and this is not that long ago, maybe well before you were at medical school, but in terms of when these trials were done, we're not talking like 50 years ago. This is in the pretty recent past. They had to have endpoints to be able to define the hard endpoint to understand whether a drug could potentially influence the outcome over here. So the clinical manifestations were pain, the pathological fracture, and going along with that is treatment for these pathological fractures, including radiation to bone, surgery to bone with rods or whatever the pin-in may be to stabilize the bone, spinal cord compression or nerve compression, and then all the way on the other end of the spectrum, hypercalcemia of malignancy. In fact, many of the drugs that you use to treat osteoporosis initially started their venture in patients in hypercalcemia of malignancy to be able to treat excessive bone resorption and to understand whether these mechanisms worked. And we'll come back to that in a moment. What you'll see over here is a definition as asterisked below as an SRE, or a skeletal related event. So when you see pathological fractures, radiation, surgical intervention, spinal cord compression, and hypercalcemia, these form a constellation of which was agreed upon to do clinical trials as a skeletal related event. And that's relevant because of how some of the therapies emerged in the field. Previously, the traditional approaches included radiotherapy, radionuclides, endocrine therapy, You're all well aware of those for prostate cancer and breast cancer. Chemotherapy, orthopedic interventions, analgesics, and then other complementary approaches. But the bisphosphonates have probably been the first foray into therapy to actually treat metastatic bone disease. Initially, pamidronate, and I know, are you guys using pamidronate still? You know, give it as an infusion, I can't remember if it's 60 minutes or what it is. Or maybe, you know, but basically, and that was initially approved for breast cancer, multiple myeloma, and hypercalcemia of malignancy. That was followed by zoledronate, which was more potent for breast, prostate, and lung, solid tumors, as well as multiple myeloma and hypercalcemia. More recently, the rank ligand antibody Denosumab, once again, breast, prostate, and solid tumors and multiple myeloma. And originally, there were some trials with a non-aminobisphosphonate, clodronate, and ibandronate is another aminobisphosphonate. So what is the rationale for the use of bisphosphonates in skeletal metastases? It's essentially, if you think about it, as you know, the mechanism of bisphosphonates, well, it's related to prenylation, but they bind to the hydroxyapatite. So they stay in bone for years. Alendronate has Fosamax has a biological half-life of 10 years. So they bind to the bone and they stick. So, you know, that is actually kind of attractive in this particular instance because they are essentially changing that bone interface such that the tumor cell finds it less hospitable to adhere and colonize the actual bone marrow. They inhibit osteolysis, reducing some of the clinical adverse events, and we'll come to that in a little bit more detail. And they also reduce tumor growth in the skeleton. So we started the introduction by talking about osteolysis and clastogenesis, and the fact is that you have revved up bone turnover. Essentially, if you look in patients with metastatic bone disease untreated, their biochemical markers of bone turnover will be high. There is excessive bone turnover. So if you dampen that down with a bisphosphonate, you are less likely to entrain and feed that vicious cycle that was going on. So the initial trials for zoledronate versus pamidronate was approved first. They had to go head-to-head because pamidronate was approved. You couldn't do placebo-controlled trials. They did double dummy, double blind studies with zoledronate versus pamidronate, so 4 milligrams versus 90 milligrams actually. And you're talking about 287 patients. They had to have a corrected serum calcium of greater than or equal to 12 milligrams per deciliter. This is hypercalcemia of malignancy by definition. The endpoints were the proportion of patients with a clinical response of the corrected serum calcium have been less than 10.8 following 10 days following therapy. And then the mean time to relapse was a secondary endpoint. And essentially what this showed was that zoledronate was more effective than pamidronate in the treatment of hypercalcemia of malignancy, and moreover, the relapse time was extended with the one agent versus the other. So the original trials way back when, hypercalcemia of malignancy goes way back when people were treating with calcitonin. Then came pamidronate, do a placebo trial at that point. Then came zoledronate, which had to go against pamidronate, and then other agents that have emerged probably haven't even gone into hypercalcemia of malignancy because the shape of the disease changes as new therapies emerge. In terms of zoledronate studies, pivotal studies, there was one active comparator trial and 2 placebo-controlled trials, and the placebo-controlled trials were for novel approvals. Primary analyses were proportion of patients with at least one skeletal-related event, which we discussed previously. Secondary analyses included the time to that event, skeletal-related morbidity, and then multiple event analysis. So the breast cancer and multiple myeloma were double-blind, double-dummy studies. And for multiple myeloma, you required at least one osteolytic lesion to participate. For breast cancer studies, they had to be stage 4 with at least one bone metastasis. Anti-neoplastic therapy, which essentially at that time was chemotherapy, was allowed. ECOG performance status and serum creatinine had to be less than or equal to 3 milligrams per deciliter because of what these drugs could do. And there's an interesting thing that occurred, and we'll come to it in a moment, is the studies weren't that long. They were 12-month studies where pomidronate was given 90 milligrams every 3 to 4 weeks for 2 hours. And then zoledronate was given as a 4 milligram or an 8 milligram dose, which was later down titrated to 4, and I'll come to that. It was given as initially as a push over 3 to 4 minutes, and then at least every 3-4 weeks as a 5-minute push, which was later increased to 15 minutes because of some tolerability considerations. Study was lasted for 13 months. All patients received calcium and vitamin D supplementation, as they do essentially for all bone trials. Just to give you some sense of these trials, the mean age of patients was around 60 years. Most patients were, 80% plus patients were female. Not surprisingly, if you've got breast cancer and multiple myeloma, there were more breast cancer patients. And, just giving you the relative breakdown with ethnicity at that time of the study, as well as those patients with breast cancer, how many of them were on chemo versus hormonal therapy. And the interesting thing, this was set up as a non-inferiority study, and essentially zoledronate 4 milligrams was no different to zoledronate 8, what was down dosed to 4 because of tolerability, and pomidronate 90 milligrams. So essentially, the non-inferiority criterion was fulfilled. The primary endpoint was the skeletal-related event. And then this just breaks it out according to what we had discussed for the skeletal-related events. They have all fractures, those patients who got radiotherapy, surgical intervention, and then who had spinal cord compression as being a very small group. And essentially what you saw is that zoledronate was really not dramatically different to pomidronate. And once again, this is looking at the other endpoints, at the morbidity rates, and it looked like zoledronate was a little bit better than pomidronate, but really not different. Once again, breaking patients down by the relative lesions, remembering then essentially what we said is you can have a lytic lesion, a blastic lesion, or you can have some sort of amalgam of it. Essentially, you get everything in these cancers, breast typically being lytic and blastic, so you're getting both. Myeloma, obviously, really a lytic lesion, but essentially this is the breast cancer patients, and you're essentially seeing things move across a continuum. So it doesn't really matter in your minds. It shouldn't matter if it's a lytic lesion or a blastic lesion. They respond pretty much similarly. Do want to just summarize, and this is the summary in tabular form, essentially, giving you a sense of the skeletal-related events, time to the first event, etc., and basically comparable efficacy of the newer agent at that time versus the traditional agent. Other studies were done as well that actually were placebo-controlled, but there were also the newer agent at that point was the rank ligand antibody Denosumab, and it had to do active comparator trials because all of these had already existed, and we can just quickly scroll through a number of these. Once again, so remember what you have happen is the standard of care continues to shift. You started off with nothing, so calcitonin then you had pamidronate, then you had zeledronate, which displaces pamidronate. Now you get the rank ligand antibody, so you're using a different comparator. So essentially, Denosumab 120 was given subcutaneously versus zeledronate every 4 weeks as a 15-minute infusion. Look at the length of the trial. It's now becoming a longer trial from 13 months to 34 months. All patients again getting calcium and vitamin D supplementation. Very, very similar. All patients 18 and above, breast adenocarcinoma with at least one metastasis, the ECOG performance. Now they're not using creatinine as serum creatinine on its own. They're talking about clearance. Very similar situation given Denosumab. But essentially what you're seeing over here is that this is the baseline characteristics for the breast cancer trial. Median age is a little younger than we saw previously. When we started, we spoke about around 60. It's not dramatically different. Pretty much almost all females, but not exclusively. And, hormone and chemotherapy, of course, being allowed. Yes?
How long was Denosumab used for, or how frequently?
34, oh, how frequently? I believe it was given at 3 to 6 monthly intervals. Let me, it's not, I didn't state this over here, but I believe that, and I'll look that up for you afterwards. So essentially, it was interesting because DMAB actually demonstrated itself to be superior to zeledronate in terms of the time to that first skeletal-related event. The first skeletal-related event median time was actually 26.4 months for zeledronate, and it wasn't actually reached in that particular study for Denosumab. And so other studies, advanced cancer trial designs were also done, excluding breast and prostate. The dosing regimen was the same, and the duration was the same, and all the other criteria. But essentially in the advanced cancer trial, all the criteria were very similar to what we just discussed for breast cancer, so I'm not going to reiterate them. The baseline characteristics, the age of the patients was around 60 years, a little bit higher representation by men, but you could see chemotherapy, hormonal therapy, and the mix of other components as well. In this particular trial, skeletal-related event, median time was about 20-something months for Denosumab versus 16 months, and essentially it wasn't superior, it was a non-inferior trial to zeledronate. In terms of prostate cancer, once again, a number of trials have been conducted. I think you're aware of the fact, documented bone mets to get into these trials, rising PSA, baseline serum testosterone really low because they're on GnRH analogs, agonists, or even antagonists. The rest of the criteria aren't any different. Naturally, being castrate, chemically, there's higher bone turnover aside from the prostate cancer metastasis itself. Stratification, the presence or absence of distant mets at initial diagnosis. Everyone's on calcium and D, and 15-month follow-up period. This was the original zeledronate study, so I don't want to confuse it with Denosumab. And essentially what you saw, so this is the male version of the female version of breast cancer we spoke about previously. They were slightly older, 72, and they were all men, okay. And you got a sense of the ECOG performance status and really median PSA, etc. Essentially, in this trial, it was placebo-controlled because the original pomidronate studies they did not go for men with prostate cancer, only for breast and myeloma. So you were able to do a placebo-controlled trial at the time, and these data are read out, I would say, somewhere about 12 years ago, 12, 15. So, I mean, it's not that long ago, which has changed the face of how you treat these patients. But Zeledronate 4 was, statistically different from the placebo. Funny enough, the 8.4 milligrams wasn't, and not sure what to make of it, but they got approval based on this. And this is the proportion of patients, men with prostate cancer with a skeletal-related event. And this is breaking it down again by the components of that skeletal-related events in terms of XRTs used pretty frequently in prostate cancer, that's metastatic to bone. The fractures, changes in chemotherapy, the spinal cord compression, and surgery, and you can see that pretty much across the board, for no matter what the modality is and the component in the skeletal-related event, that drug therapy is better than no therapy. That's the point of that, and this is the mean skeletal morbidity rate. I'm not going to go into that in great detail. Once again, just going through the data in tabular form. So if we now go to the trial, Denosumab every 4 weeks in this trial, but I don't know what, I assume it was as frequent in the others as well. But anyway, so the prostate cancer trial, when it was compared against Zeledronate, all patients calcium vitamin D, Zeledronate was 4 every 4 weeks, and Denosumab 120 every 4 weeks, and the follow-up was longer than 12 months. Similar age as in the original study, and I think the PSA being greater than 10 is pretty similar to what we had seen previously. Essentially, time to first skeletal-related event was prolonged with Denosumab when compared to Zeledronate. So the rank ligand antibody appeared to be more efficacious than the bisphosphonate, for what it's worth. Remembering when I showed you those slides of the pathophysiology, you got the rank ligand amplification. If you don't mind, I'm just going to go back. So remember that when you got the cycle going on and the tumor cell releases PTHRP and you got the osteoblastic, rank ligand increased. So as opposed to the bisphosphonate, which is generally going to bone and doing its thing in a broader way, you could argue that perhaps this is more mechanistically targeted to a component of what's going on. And so basically, that the skeletal complications in prostate cancer were decreased and was superior to Zeledronate, and that gave the labeling and the use of Denosumab for this particular indication. In terms of future therapies for metastatic bone disease, it remains an interesting area. Bisphosphonates, there are other bisphosphonates, I won't go into that. Integrin antagonists haven't quite found their way in the world for bone. The osteoclast, when it binds to bone, the osteoclast has an integrin on it, the alpha V beta 3, which recognizes a special motif in bone called RGD, and it binds. And so integrin antagonists were tested in states of high bone turnover and decreased bone resorption and increased bone mineral density, and there was a desire to consider bringing them forward. The reason being is that both breast cancer and prostate cancer cell lines express the same receptor, perhaps what allows them to actually bind to the bone as the osteoclast does. So that was the hypothesis. But these agents really didn't get the traction. Cathepsin K inhibitors. So cathepsin K is a cysteine protease. I wonder if I have a picture. I don't. If you give me a moment, I may find something. Cysteine protease that actually binds to, I'll just show you something. Oh, okay. This is from a review that's quite old now. But these are the pathways for anti-resorptive targets, okay? So the osteoclasts, the precursor, rank ligand, da-da-da-da. And then what happens is you have the osteoclast that's bound to bone. And you know the osteoclast releases acid, which sort of demineralizes that calcium phosphate on bone. So that exposes collagen. 90% of bone is type 1 collagen. So it also releases, so you have your very low pH in that resorption pit. And it also releases, it has these lysosomes that release cathepsin K. Cathepsin K is an enzyme that digests that collagen, the type 1. 90+% of bone is type 1 collagen. When you digest that with cathepsin K, that's how you denature the other element of bone. So you solubilize the calcium phosphorates, and then you digest the bone matrix. So what I wanted to just use this slide for is to say, there you've got the integrins that allow the osteoclast to bind to bone, but these cathepsin K inhibitors digest bone. And so another possible approach could be is, at least speculating, is that you could treat metastatic bone disease potentially with cathepsin Ks if anybody would develop them for that purpose. The reason behind this is as well is breast cancer and prostate cancer, also have cathepsin K involved in this whole thing. So that's the story of metastatic bone disease in a nutshell. It's not something that I think that you probably typically see in fellowship, but it's something that you certainly ought to be aware of with heightened sensitivity as you practice or do whatever else you do going forward. So I'm going to pause there and stop and see if there are any additional questions or comments.